If you eat poorly, if you go have a donut, you're going to feel grumpy and irritable and or hungry again. An hour or two later, you're going to feed yourself and you're in this vicious circle. And then you may feel horrible again an hour after that. And to know that gives you some insight. And that goes back to ourselves as a lab. Glucose and insulin is pretty silent. But there are some of these telltales. Oh, I get grumpy and irritable. I didn't realize it was related to what I ate 90 minutes prior, 2 hours prior. Who would have put that together?
I think a lot of people don't connect the dots and understand that often these hypoglycemic crashes are driving behavior. I also see it driving anxiety and panic. Some of the things that we tend to pigeonhole as mental health effects, they're actually related to your physiology. Our guest today is Dr. Brad Jacobs. He is a medical doctor that I've known for 30 years, dating back to when we were interns in our cute little white jackets at the University of California, San Francisco. So, Dr. Brad Jacobs, I'm so excited to have you here.
It's a pleasure to be here, Sarah.
So we're going to get into who you are and your mission in just a moment, but I wanted to say just a few introductory comments. First, I wanted to say to our audience that even though I'm known for my work in women's health, half of my patients are men. So it's a thrill for me today to talk to you about reclaiming masculinity, longevity, and just mine the depths of what you know about men's health. This podcast is about how all of us are treated, not just one gender or another. I definitely believe that women need and deserve to have the kind of attention that I want to bring to them in this podcast, but I want to make sure that we also are speaking to men and speaking to all the people who love women. Now, you're the real deal. And I want to get into your mission and who you are for people who haven't heard of you yet. You're a Stanford-trained medical doctor. You have a busy primary care concierge practice here in California, and you offer the best of conventional medicine paired together with more upstream approaches like precision medicine and functional medicine. And you started doing this, I would say, like 50 plus years ago with your interest in martial arts. People don't know that you're a multiple black belt in deep contemplative practice for as long as you have, but they're going to learn about that today. So why don't we start first with who are you and what is your mission?
It's great to be here, Sarah. I really been looking forward to this time that we get spent together in this format and to sort of go back and forth and dialogue and have some playtime and some curiosity. And so to answer your question, who am I? It's a big question. I would say I'm a seeker. I'm someone that's always, since I was a young kid, been looking for what's underneath. What's the mystical? Why are we here? How do we find our way? And how do we bring more love to ourselves and to others in the world? And my mission is really just that. My mission is really to, as of getting older here and entering my 60s or now well into my 60s, really to learn to bring more love to myself and to everyone else. And I think there's a huge amount of healing that can come from that. And frankly, I used to think that was so wishy-washy and new agey and complete bullshit. And now I've been able to have direct experience of what that means and map it to our physiology.
Mm.
So, but
a little preview of coming attractions. I like that. So seeker, and I feel like when I first met you, one of the moments I remember is being at San Francisco General Hospital and being in the cafeteria. Remember the cafeteria?
I do.
At the salad bar, and you didn't know like how long those different things were sitting there in the salad bar.
Yep.
And it was always a little dicey eating in the cafeteria. But I remember seeing you, and you had that seeker look to you. It was in your eyes. You've always had it. It's been a through line. What did it feel like then when you were an intern? How was it manifest?
Yeah. It was hard as an intern. I came into medical school with a plan to change medicine. That's the only reason why I went to medical school. I was deciding between medical school and Chinese medicine school, having grown up doing martial arts since I was a kid and steeped deeply into Chinese martial arts in particular since I went to college. So I really went in there with that intention, like I'm going to learn what I need to learn and I'm going to get the hell out of here and do it my way and teach everyone the right way to do it because I was filled with pompous and arrogance and hubris. But it's true. I mean, medical school, as you know, what we're trained to do is dispense medications, recommend procedures, and send people to surgery. We don't know anything about life. We just focused on diseased matter. So for me, I was always looking for the mystical as it relates to the dynamics between me and my patient. So that was a time where you could meet heart to heart, where people were afraid they were going to die. They were in the hospital dying or, being this close to dying. And those were the moments where people's deep, deep humanity showed up.
It's true. I remember at San Francisco General and also at Parnassus, the University of California, San Francisco sort of main campus. We had a lot of patients that were dying of HIV back in the 1990s. And it felt like there was a way that our hands were in life and death every day as we were taking call. I want to circle back to this point that you're making about changing medicine. So you and I both had this sense that the healthcare system was broken, that it needed to be changed. We also had this sense that 75% of healthcare costs were lifestyle diseases, were things that could be addressed with a preventative approach. And yet, as we went through our medical training, we also learned that prevention was a hard sell. So what's happened with that initial mission that you had when you entered medical school at Stanford to change the medical system? What's happened over the past few decades?
I would say personally, I stayed in the belly of the beast. I chose to, before I went to medical school, I got a master's in epidemiology and biostatistics at UC Berkeley. And then I went to medical school, did my full training, medical school, then UCSF for internal medicine training. And then I did a clinical research fellowship to just make sure I had more research training under my belt. And I came out with a lot of hope that we could change the system. And I chose to stay in academic medicine for, a decade after my training. And frankly, I realized this is not the place for innovation. They innovate at a high tech level with robotics and in the lab. That's great. But innovation of changing healthcare delivery systems, not so much. And frankly, UCSF, I was fortunate to be the founding medical director and the endowed professor at UCSF for the Osher Center for Integrative Medicine. And what a beautiful opportunity, frankly, that was. And it was the beginning. We were the first handful of academic institutions that had a center for integrative medicine. And it was a huge opportunity for innovation and creativity. But frankly, the only reason why we were allowed to be there is because they got a $10 million grant from the very generous Oshers, the Osher Foundation. And otherwise, they wouldn't have tolerated us. And, a whole bunch of white-haired men in white coats, white-haired white men in white coats were the, responsible for determining what we would be able to have in that practice. They didn't want herbal medicine. They didn't want chiropractors. So our acupuncturists that were highly gifted had one hand tied behind their back. They could only do needling. So it was somewhat limited. With that, we did beautiful things, and we got ourselves, wrapped into the belly of the beast in the hospital setting. And I remember intentionally seeking funding in order to get ourselves into the hospital setting to show that post-operative cancer patients, particularly it was women with post-operative cancer patients in the hospital, would actually do better with the integrated medicine post-operative treatment course. And they did. We published it. It was great. But if you look at a large scale, at a mass scale, it hasn't changed much.
That's right. Yeah, it's interesting to me. There's a lot of people who claim that they're trying to change medicine. They're bringing about medicine 3.0. And I feel like in some ways, you're the truest expression I've seen of this. With your background in internal medicine, your background in outcomes research, you've got the chops to be able to do this. When you did your research fellowship, because I was tracking all of this and tracking you as you went through this process, I remember you were working with Deb Grady and Carla Kurlikowski at UCSF, and it was right when the HERS trial came out in 1999.
Yeah.
And a lot of people think the Women's Health Initiative was the first study looking at hormone therapy, at least the conjugated equine estrogen and medroxyprogesterone acetate, as dangerous and provocative in terms of primary prevention of cardiovascular disease. But it was the HERS trial that was the first study to show that it was potentially dangerous and provocative for secondary prevention of cardiovascular disease. So I want to give that context. And then you went on to do such important work on milk thistle, on low back pain. What were some of the other studies that you were involved in?
Yeah, so during my clinical research fellowship, I was fortunate to be under the mentorship of Steve Cummings, who's associate clinical director for clinical research there. He's like a dean there.
A giant in this field.
A giant, particularly osteoporosis, right? And just a mensch, just a beautiful man. And, we had Deb Grady and others. So I ended up doing a systematic review on milk thistle, which was really interesting. And it was really interesting to have my own. That was my first moment of realizing, I can read through the lines of the literature and know what actually they weren't able to publish and talk to the authors of what they weren't able to actually get in the papers. And then what was actually published. And then then what we had to write up and put in the actual paper, which was far more conservative than the truth, right? So,
Okay, I want the truth. So what were some of the things that you were getting between the lines? And do you still prescribe milk thistle now?
Yeah. So milk thistle done in the right prescribed dosing. Yeah. I mean, there are so many mechanisms by which milk thistle helps the liver. And, both at the cellular level, as well as the physiologic level, as well as phase 2 detoxification. I mean, it's amazing, actually. And I do think it's life preserving and life saving. But the data, if you're rigorous about it, it doesn't fully show that. So we were sort of yeah, there's the potential here for good, and here's some secondary outcomes that showed benefit. But the truth is, I'm a big fan of milk thistle. And silymarin, which is the main active ingredient, although there's psilocybin and a couple others. But so that was the first one, a systematic review on milk thistle, published in the American Journal of Medicine. And of course, it took forever to get it published because back then, no one really wanted to publish about herbal medicines and what was called complementary and alternative medicine. Then we went ahead and did the first online clinical trial. So that was with Steve Cummings, and he recognized that it takes so long and it's so limiting to patients. If you live in Washington and the clinical trial is going on in Georgia, you can't participate. So we did the first direct-to-consumer online clinical trial. So we were able to screen 15,000 people and randomize 381 of them within 8 weeks, which was unheard of. And they were from every state of the United States of America. And we looked at kava, a herb called kava, and valerian for sleep and anxiety. So that was fabulous. That was really fun to do. And then, I went on to do the yoga.
Oh, wait, what did you find?
Well, we found a huge placebo effect.
Yeah.
So 50% improvement in sleep with placebo. So it was really hard to compete against that. So we did not show much benefit between valerian and placebo. And we showed some benefit for anxiety with kava versus placebos. Yes, it was a 3-arm randomized controlled clinical trial, which was awesome. And and the people loved it because we shipped the herbs to their home. We had home diaries that they did. It was all done remotely, which
is super innovative.
Which 25 years ago, keep in mind, and this is 2002, was pretty innovative and a lot of fun. And that was sort of the early markings of what we later went on and created a company around. It was a CRO called Mitris that was later acquired by Medidata, which is a larger CRO focused on doing direct-to-consumer clinical trials where we would disintermediate. And frankly, the theme of what we should be talking about is how do we disintermediate the systems? Because the healthcare delivery system and the hospitals, the pharmaceutical drug companies, the insurance companies are all getting in the way of us empowering ourselves to be in good health. I mean, let's be honest about it. Everyone's trained, doctors are trained to prescribe drugs, not to help you live longer and healthier lives through self-care and other means. They don't have the time for it. They're not trained in it. And who gets in the way? Insurance companies decide what we can and can't get. And they're making millions and billions of dollars. And the classic delay and deny methodology of insurance companies, they're all getting in the way of us empowering ourselves to live healthier lives. And that, frankly, is the number one thing we should all be focused on.
Okay, so if we're going to focus on that, how do you focus on that with your patients?
I think the primary focus is empowerment through having ourselves as our own laboratory. And one of the main things I learned growing up is making my laboratory my own body. As a martial artist, I started when I was 8 years old. And the beautiful man, the young guy, my buddy who got me into it, 6 months into it, he dropped out, but I loved it. So I kept doing it. I was doing Tong Sudo, which was Chuck Norris Studios in Los Angeles in the 70s. We're going way back now. It was amazing for me. It was so liberating, empowering, and, it built both confidence and humility at the same time. It built, ability to persevere and have grit, and at the same time be wild and crazy and spontaneous. Like, it had all these seeming polarities, and hopefully maybe we'll have a chance to talk about masculinity and femininity and what that's about. And it's really about that, these things that seem separate but really are best when they're paired. So that taught me to be my own laboratory. And I think for yoga, the same thing, right? Which I later learned in life. And I know you're a yoga teacher and deep yogini. And the beautiful thing is, if we become our own laboratory, we can see all the differences that happen in our life. And now, in the past decade, there's all these wearables we can put on our bodies that help sort of give objective versions of what we're subjectively experiencing. So I think empowerment is through self-exploration and community with one another.
That's potent. So with wearables, let's take wearables for a moment, because I get a little more obsessive maybe about my wearable data than you do. So tell us about your relationship with wearables. What do you use, and how does it help you with your body as a laboratory?
Yeah. So I think you've heard me say this before, but we want to make sure the tail doesn't wag the dog. The dog has his tail, and when he's happy, he gets to wag his tail. But if direct our life by what our data is showing us rather than what's showing up with us internally, then we get everything backwards. So I'm really a strong proponent of telling people, check in with yourself before you check your data, your objective data.
I think that's a Beastie Boys song. Like, check yourself before you check your data.
Yeah. I don't know about check your, is that how it goes?
No, I don't think they can. I might be making that up.
Yeah. So you got to check in. So there's this concept of interoception, learning to sort of gain an internal milieu awareness. Hopefully we'll maybe get into Hakomi and talk about, mindfulness-based somatic-oriented psychotherapy.
Yes, please.
But let's explore our internal environment and then wake up to how we're really feeling in the morning. Yeah. So my favorite wearables are CGM, continuous glucose monitors, which now are over the counter.
Do you have one that you're wearing?
I'm not wearing one now.
Because I've got mine on.
You do? Which one do you like?
I've got the Dexcom.
So I'm torn between the Freestyle Libre and the Dexcom. Dexcom's got the over-counter one called Stello, I think it is. Yeah. And Freestyle Libre is coming out with Air soon, I believe. They're both great. And there's some interesting new companies out, right? Levels, NutriSense, I think is a new one also coming out. That layer, sort of have an AI layer on top of it. I think it's great. And I learned so much from that CGM. I don't think people need to wear it all the time. I know you like to wear it pretty often. I
like the Hawthorne Effect.
Yes.
So I like...
Let's explain. What is the Hawthorne Effect, Dr. Sara?
How would you define it? I would define it as I behave differently when someone else is watching.
Yeah.
So I'm less likely to have the tortilla with the beans and, maybe the mango salsa if I've got a CGM on. I'm more likely to choose the chicken thighs and the things that are less likely to crank up my glucose. So the Hawthorne Effect is where someone else is watching and you change your behavior as a result of it.
Right. Or you imagine someone else is watching.
Or you imagine someone else is watching.
Yeah, it's funny you say that because yesterday this exact same thing happened. I went out to to lunch with my physician colleague at Blue Wave Medicine.
Hi, Keith.
Yeah, hi, Keith. We love Keith. And he's like, with a CGM on, it totally is changing what I'm ordering. So that was great. He did a salad with rotisserie chicken,
He showed the Hawthorne Effect.
Yeah. And what I tell patients is, though, eat like you normally eat. Like, come on, don't put on a show for everyone. Like, slap on that CGM and let's see what you got. Let's see how you live your life. And then we can reverse engineer. And look, to be fair, I really think quality of life is important. And so no one wants to live to their 130 and be miserable their whole life. So there's some balance there between enjoying what you're eating and managing your metabolic health, which is looking at your glucose and therefore your insulin.
This is a really critical point because I remember when I went through my training at the same time as you, one of the concepts of longevity was to undereat, right? So we knew with worms, we knew with all these different studies looking at animals that if you reduce the number of calories that you have each day, that these animals live longer.
Yeah, caloric restriction.
Yeah. And so I always felt like that is not how I want to live my life. Like, I really find that food is such a source of pleasure. I love to cook. I love to, just enjoy the sensuality of food. And so caloric restriction never made much sense to me. Plus, it's an utter failure on a large scale, right? So if you look at 100 patients, maybe 5 of them are successful with caloric restriction.
Right, for sure.
There's other pathways that we can activate for longevity that don't require a hit to your quality of life.
Yeah. But, just to talk about that for a moment, caloric restriction. So, if you look at the blue zones, right, and a lot of them, those folks are calorically restricted, but they don't restrict themselves. It's not a conscious restriction. It's a cultural difference. And I think that's a big difference. Because in America, it's the land of plenty, and there's a land of choice, so much choice that we get overwhelmed, frankly, that it's overwhelming. And now we have to restrict ourselves, and now we're feeling deprived. And so there's that whole psychology. And the other piece is, let's just take Europe. People spend hours at the table eating. And so you'll notice when you're full. The problem is that we eat within 7 minutes, and we're going to eat a third less if we actually took our time, because it gives our stomach time for its signals to register to our brain to say, you're actually satiated, you're full, you don't need to eat so much. So I think it's an interesting cultural phenomena. And, going back to our residency training, we were eating literally on the run, right? There was no time to really stop and enjoy a meal.
It was the opposite of interoception during our training. So you and I met Dan Buettner, who is the one who's written so famously about the blue zones. So when you're invoking the blue zones and kind of this cultural way of approaching food and satiety, I imagine you're thinking of Okinawa as well as Europe, maybe the Nicoya Peninsula in Costa Rica. And I think this is a really critical point because there's a way that in the US, part of what I was taught growing up was to eat to change my emotional state. And I think that's something that you see much less in the blue zones. What do you think?
Yeah. So I think about food, for sure, most of us wrap love around and connection around food, right? And so we're growing up and, joyful times, holiday times, all the movies that make up about the holidays of people coming around the table with food. And then so many of us are so lonely, but we still have food. So we use that food as a surrogate for our love and connection, even when we're eating by ourselves.
Yeah.
And then we probably eat more because we don't have that connection. It's missing. And we don't recognize that's what's happening, but that is what's happening. And what I was going to speak into is, I think the blue zones, the main secret sauce is connection and community. That there's a sense of connection and community. And therefore, back to what you asked me about the mission, my mission, feeling loved and being able to love others. And so you're in relationship with others. And in being in relationship with others, I'll never forget, I spent some time between college and graduate school. I spent a year in Africa. And I did that because, frankly, I grew up in Beverly Hills. I grew up a rich brat. I felt totally out of place there. I never wanted to be there. And I tried to do a counter experience to that. So my first counter experience was I figured if I moved all the way across the country and went to college across the country, that would be a very different experience. And of course, it was not, because I went to a private university, Tufts. So then I said, okay, I'm going to Africa. And I remember being in Africa, and I was in Zaire, which is now called the Democratic Republic of the Congo, DRC. And I remember the sense of accountability that you go to these villages and people knew each other for generations and generations. And so people would act in ways that were always aligned with a sense of accountability. Like, you can't just show up tomorrow and pretend nothing just happened today. And that's gone with urban living. And a dear friend of mine that I learned when I came back and I learned Swahili in medical school, as a follow-up, which is a whole nother story. But, and I remember my teacher telling me, and he became a friend, and he said, there's no accountability here. Like, and this is what happened in Africa as well. When people moved to the cities, they lost that sense of accountability because there's no sense of community. And that loss of community, we just change how we act, and we don't feel the restrictiveness, and we have to abide by these laws and rules, and we feel bound by. It's more a sense of belonging, and we don't want to risk that sense of belonging. So we act much more in line with what's better for all of us, right? Yeah.
It's such a good point. So I want to take our listeners back to you in high school. You're in Beverly Hills. You're 90210. And you went from that, quite privileged background and experience to being in Zaire. Like that's kind of unusual. Can you tell us about some of what was at the root of that? Like, what was there, a longing or like a stirring, a desire for more mystery? Like what was at the root of that arc?
Yeah. I still wonder, I think, first of all, I was in 90210 before it was 90210 publicly,
Right,
just for the
right.
record. I predated the TV show. I never really watched that TV show.
I didn't either.
Yeah. So I grew up in the 70s in Beverly Hills. So what was that? Sex, drugs, and rock and roll. Quaaludes, cocaine, everywhere. And, parents had it, people were all doing it, and it's total debauchery and decadence, and people were having a great time and miserable at the same time, and people were dying. Like we had, we knew parents that overdosed, that we knew the divorce was happening everywhere. These are celebrities, these are professional athletes, these are musicians, these are, very successful business people, and they were, frankly, what I experienced is pretty miserable. And so wealth definitely did not equate with happiness, sense of fulfillment and contentment. And so that American dream is really, in my mind, at a young age, it was complete bullshit.
So when did you realize that? Because it's unusual as a teenager to understand that wealth does not equal happiness.
I just witnessed it. I witnessed overdoses. I witnessed people flipping their cars, which we all did, teenagers doing that sort of thing. I don't know if we all did, but lots of different
I was in the library.
people. Right.
I was not taking Quaaludes.
Yeah. Quaaludes are one of the best drugs ever. I have to say, Roar 714, it's an unbelievable drug. They haven't made one that good yet. Maybe MDMA is a strong competitor. There's a reason why they took it off the market. So I saw people were really unhappy, and I also just felt out of place. And there was a lack of depth. There's a lack of true depth of meaning, connection, relationship. Everyone was so transactional. In the parents, right? There's a sense of transaction. There's a sense of Arthur Brooks talks about deal friends. So not real friends as deal friends. And for me, just something felt amiss. And so I was always searching for something different. So I went to Europe. I was fortunate. I traveled around Europe. And when I graduated from high school, on a Eurail pass in my backpack with my best buddy and then our girlfriends for part of that trip. And then I, went to college on the East Coast and literally found myself right back where I was, like literally the roommates were doing cocaine in the room next to me. And they're like, California boy, come on in, and, there must have been something about my buddies in elementary school and high school always called me Nature Boy. So, you know, Beverly Hills kid called Nature Boy. So I think, from my upbringing, I've always sort of resonated with natural habitat. So there's that. And I realized, oh God, I did not land where I wanted to in college. And then I needed that right-sided experience, and it right-sided me. And what it really did for me is realize that our cultural norms are complete constructions of our mind, that it's an illusion, that it's not truth, and not to believe our thoughts. Like the ancient and wise elders say, contemplative practices, that your thoughts are illusions, and don't believe everything that you think, because it's illusion. If you wait long enough, you'll see the mystery goes away, and what you thought was so true is actually illusion. And I saw men walking hand in hand, holding hands. I thought they must be gay, right? They weren't gay. This is what men did in Zaire. They walked hand in hand with each other, and there was no problem at all. And then the flip side, I saw women having the clitorises removed and being painted with white faces, sitting up on the hillside in utter agony for days at a time, having just had their clitoris removed. So like, you're in this world with like their cultural norms are very different than mine, and everyone is aligned and okay with those cultural norms, and yet I'm seeing them in such contrast to how I was raised. And it sort of blew open my mind to, oh, this is all illusion. This isn't real. We should create our realities how we want to construct it. And so that goes back to healthcare. We need to create a healthcare paradigm how we want to construct it that's right for us, and not accept what we've been given, which is there's insurance companies, there's pharmaceutical drugs, and that's what we're supposed to just do. No, that's not what we're supposed to do. We need to find our own true self, find our connection, create community, engage in our wearables, and mine our own selves, and engage in daily self practices that will bring our vitality, our gratitude, our love, our sense of awe, a sense of wonder back into our lives again.
When I think about you as a teenager, you've got this transactional world that you're growing up in. You're embedded in the ecosystem of Beverly Hills. But you also have this really rich world of martial arts, which goes so much deeper and is not transactional. So how did you weave those together? Like, how was that then map to the way that you approached medicine, approached your career?
Let me think about this for a moment. So, to rewind, so from ages 8 to 12, I practiced martial arts, Tong Soo Do. I was so close to getting a black belt. I was so excited. And then we moved. I was in Sherman Oaks in the valley, San Fernando Valley, before there was Valley Girls and all that too. And we moved to Beverly Hills, and that's, when we were very unhappy about that move. And then I was no longer able to get to martial arts school. And so from ages 12 to 16, no martial arts. That was rough. It was really rough. As soon as the day I got a car.
You started going again.
Yeah. And I went to Dan Inosanto, an amazing human being, an amazing trainer, amazing martial artist, one of the grandfathers of the Okinawan styles of Eskrima and Kali, and a brother of Bruce Lee, trained with Bruce Lee regularly, and taught Jeet which is with Bruce Lee's style, JKD, and Eskrima and Kali. And I was fortunate I would drive down to Torrance. I mean, I would drive 45 minutes each way. That's how motivated I was.
Most teenagers were not doing that.
No one. I didn't know one was doing this, actually.
There's something different about you, Brad Jacobs.
Yeah. There was something about that sense of deep connection, because frankly, when you're sitting there across your opponent, who's your friend and buddy, but you're like going to take him out, but you're not going to literally kill them, but you're like you're looking at each other and it's full on, and it's like purism, it's pure presence, it's pure intensity, and it's that pure primal fight. Um, there's a rawness to it that brings such aliveness to your life. And it cuts through all the materialism that we live in our day-to-day life. And I think that is the through line. And thank you for sure bringing that back into my consciousness. I think that is really what fed me and showed me that it's real. It's not some conceptual thing about trying to, be rooted in being nature. Like I was living it and feeling it, and like you could feel the rawness of it. And anyone that's been in, practice martial arts or different versions of different sort of interactive practices. It could be interactive dance, could be interactive yoga. It's in chess, like it's in a lot of places where you're with it's in competitive sports. There's that raw primal experience, and that there's nothing like it. And, we walk around feeding ourselves and dressing up in silly outfits and doing all this stuff. It's all sort of
Silly.
silly. So I think that's the through line. That's what's fed me. And I feel like for me, for medicine, is that too. It's about life and death. And it's about, while you're alive, living the most vital, vibrant life you can. How do you shake the other parts out of the system and yourself and others so that you get to that root aliveness, And by the way, none of that was taught in medical school, right? Like, what do we learn about that in medical school? Nothing.
Well, my experience in medical school was maybe a little bit different because I had David Eisenberg as a mentor. He had just published in 1993 his paper in
JAMA.
JAMA.
Or New England Journal.
I can't remember which one it was. We'll have to find that for the show notes. But he's the one who found and documented for the first time that a third of Americans were using complementary and alternative medicine. And that was a huge shock to the medical system. Here, this professor at Harvard was talking about complementary and alternative medicine and how doctors and other healthcare professionals need to start asking people about what they're doing besides, the pill for every ill. So he taught a different way that I found made a lot of sense and fit with my own experience with practicing yoga from when I was 5 years old and with transcendental meditation that I learned in college. So his model made a lot of sense to me, but he was like 0.1% of the exposure that I had to medicine. So when we go back to the medical system, what does conventional medicine get wrong?
Can we just put a pin in that for 1 second? So can you tell the audience and me a bit more about how you fell into yoga at such a young age?
I had a great-grandmother who practiced yoga, and so she learned it in the 50s. She was in Palo Alto, and she was a radical. She lived until 97, fell asleep, basically didn't wake up from sleeping at night. She was on no chronic medications. She practiced yoga pretty much every day. And so when I was 5, she taught me how to do yoga. And I would go with her to classes. I would go with my mother to classes. My mother had a lot of symptoms and had trouble practicing yoga. Like she'd get a headache when she did inversions. And so my great-grandmother was a huge influence.
Yeah. And why'd you keep doing it? Like most kids would be like, thanks, great-grandma. I'm good.
I needed it. So adverse childhood experiences, I had a score of 6. I needed it to regulate. I didn't know it then, but there was something that just locked into place when I practiced yoga. There was something about slowing down my breathing, something about getting utterly present and witnessing the experience of my body that just made so much sense to me. And so it's been a through line for me my entire life. It's how I survived medical school. I don't think I would have survived unless I went to Kripalu at least once a quarter.
Yeah. So as you say that, I'm reflecting on myself and I'm realizing that's how I use martial arts, because I've never really looked at it that way, but my family life is pretty dynamic and emotionally alive, shall we say. There's a lot of disturbance going on, and that place was a place to channel it and move that energy through and ground and get to what's real. Yeah, that's really interesting. Thank you for bringing that up. So back to your question about what do they get wrong in med school?
Yes. Dr. Jacobs,
Yes.
what does mainstream medicine get wrong about health?
They're focused on disease. They're focused on not only disease, but even more basic than that. Disease as it manifests in physical matter. So if it doesn't manifest in physical matter, for the most part, they don't recognize it as disease. So meaning if your kidney is diseased, then you have a kidney problem with your kidney. If your liver is diseased, but it has to show up that way in the ways that we measure it. So if a Chinese medicine practitioner or Tibetan practitioner or Ayurvedic does a diagnostic, let's say it's pulse and tongue or belly diagnosis, and says your liver seems energetically out of whack, a Western doctor will be like, "Pah, that's nonsense. I did liver enzyme tests on you. Your AST and ALT and GGT and total bilirubin and alk-phos all look fine." That doctor doesn't know what they're talking about. False. So that's what the focus is on. And, I wouldn't say they have it wrong. There's truth to it, but it's all the way at the end of that spectrum of disease. And now we're trying to treat something when we could have started looking at it 10 years before. Let's take as an example, diabetes. I know you're steeped deep in this, so you're well versed at what I'm about to say, which is our metabolic health. And what do people measure? They measure hemoglobin A1C and they measure fasting glucoses. That's it. So that's the very end of the road. Maybe some of the more wise people will back it up a little bit, and maybe typically during pregnancy, we'll do glucose tolerance tests. So what is that? We fast you, we check your glucose, we give you a slug of sugar, typically 75 grams of sugar, which is roughly 2 Coca-Colas. And then most of us feel like shit. And then, why? Because our glucose spikes and then plummets and we get hypoglycemic. And then you measure your glucose. And for a lot of people, actually, their pancreas is so well preserved and doing well that their glucose stays stable. And so that's a little bit ahead of the curve. But then, like we both know, actually you can look at insulin, right? And insulin will show you deviances a decade before that you see glucose disturbances. So we could do the same test and look at your insulin levels, fasting 1 hour, 2 hour, depending on how people want to do it. And you can see much earlier, let alone energetics, right? Let alone what Chinese medicine or everything. So they're focused on matter, disease, pathology at the end of the story. And they're bound by, frankly, the insurance companies. Like, we're trained to be focused on what we can bill for. And so we create ICD-10 codes, and we're bound by a DSM. And so we've limited ourselves, we put ourselves in a box. And we're focused on medications, procedures, things that are all sort of downstream. That's my point of view.
So it sounds like the problems with mainstream medicine, what it gets wrong about health, are number one, it's disease-centered. It's not health-centered. Number two, it looks at end stages of an organ system that is failing, such as a glucose hemoglobin A1C that is off, which can occur 10 to 14 years after insulin starts to show a change. It's also bound by insurance companies. Since you brought up glucose and insulin, and we know that 93% of Americans are metabolically unhealthy.
Say that, and so 93%.
93%.
Which 9 out of 10 people. So most of the people listening right now need to be thinking about this.
What do you do to assess metabolic health in your patients? Because you don't want to be one of those doctors who waits until someone has a hemoglobin A1C that's starting to climb 5.7%, 6.5%. You want to intervene as early as possible. So how do you approach that in your concierge practice?
Yeah, so we do these things called glucose tolerance tests, but they're insulin and glucose tolerance tests. I'm a huge fan of it. And so it's, we test fasting insulin. We give the slug of sugar, and then we do periodic testing over 2 hours to see how their insulin and glucose changes. And it's shocking to see what we find. I find people with a hemoglobin A1C of 5.1, 5.2, 5.3, which is really good, right? Your ideal hemoglobin A1C is 5.5 or less, is optimal. And I
I
see,
like 5.2, just saying.
right, because you're an overachiever. So, there's some, back to what we were originally saying, there's quality of life and there's in how we want to live. And if you have high quality of life with hemoglobin A1C of 5.2, all the power to you. Not everyone feels that way. And that's okay. We're each allowed to have our own.
Well, I have insulin resistance, so I think it's a little bit different when you have insulin resistance.
You're right. And insulin resistance meaning?
Meaning that my cells are a little numb and kind of asleep at the wheel. Insulin doesn't get glucose inside of cells the way that it's meant to. My insulin's on the higher side. The first time I checked it in my 30s, it was in the 20s, fasting insulin. I like fasting insulin about 4 to 6. What do you like?
Yeah, less than 10. So yeah, great. 4 to 6 would be great. I tell folks, less than 10 fasting's great. And when we slug you with sugar, ideally it's under 25. Your insulin stays under 20, 25, and then your glucose is stable. What's really interesting to see is we see people, there's a couple learnings I get out of this. Number one, let's say you're metabolically healthy, but what can happen, and I don't know the data on this piece, if there's actually predicts metabolic disease, but people that get hypoglycemic, so you see people, right, their insulin level, let's say it's relatively good. Let's say it's 4, and then it goes to 20, let's say hour 1, but their glucose goes to 60 and they feel horrible. That's me. It's really good to know that, because no wonder, what does that mean? In my mind, when I see that, I tell people, if you eat poorly, if you go have a donut, you're going to feel grumpy and irritable and or hungry again an hour or 2 later, and you're going to feed yourself and you're in this vicious circle. And then you may feel horrible again an hour after that. And to know that, and that gives you some insight. And that sort of goes back to ourselves as a lab. And I will say that with glucose and insulin, it's pretty silent. But there are some of these telltales, like, oh, I get grumpy and irritable. I didn't realize it was related to what I ate 90 minutes prior, or 2 hours prior. Who would have put that together?
This is a critical point, because I think a lot of people don't connect the dots and understand that often these hypoglycemic crashes are driving behavior. And I also see it driving anxiety and panic and some of the things that we tend to pigeonhole as mental health effects. They're actually related to your physiology. So there's this interrelationship between insulin, glucose, and cortisol, the stress hormone. So I feel like that's a really critical point. I also want to put in the show notes that, just as you described, you can do this static testing, maybe with your mainstream medicine doctor or nurse practitioner. You get a blood test once a year, and they look at hemoglobin A1C, and they say, oh, it's 5.5, you're fine. But what we know from the data with Michael Snyder at Stanford is that if you then put a continuous glucose monitor on those people, about 15% of them have prediabetes, about 2% have diabetes. So that's the science side of it.
Yeah, can I add one more thing?
Please.
So I think that the other thing to talk to your doctor about, if you don't have the good fortune of having someone that's going to be testing these, doing a glucose tolerance test with insulin combined with it, and if you can't persuade your doctor to do it, you can get the doctors to do an insulin resistance score. And so that what is that? Fasting insulin, and then they'll calculate an insulin resistance score, and that's also really helpful. Again, it's, even better is to look at the post-challenge insulin, but this at least will calculate what your insulin resistance might be, and I think that's really important for people to know about that.
Great point. So I've seen LabCorp and Quest do the insulin resistance score, although I would also say, since I've got continuous glucose monitors in so many of my patients, that it's less sensitive than I would like it to be. Like, I find the daily metrics, knowing that someone has a mean glucose less than 100, a standard deviation less than 15 milligrams per deciliter, I find that to be more helpful. But it's a good start.
Yeah, it's a good blend. And just to reiterate back on the CGM, so they're over the counter now. So that's great. So you don't need your doctor to get a prescription. You can go straight to the pharmacies and get them yourself.
So, what I want to talk about next, maybe in our second podcast, is the energetics. So, you were talking about these ways that mainstream medicine approaches health in the wrong way, and you invoked, the traditional Chinese medicine practitioner or the Ayurvedic practitioner who's looking at the energetics of the body. And so I want to pick up with that on our second podcast. As we wrap up this first podcast, anything else you want to say? Anything that I left out that you're dying to share?
I am. Yeah. I don't know if, yeah. Well, let me share it and see if you want to save it for the next podcast. But thinking about upstream events. So we talked about insulin as an example, but what about the mind? And what about our prior, you mentioned, early childhood experiences and early adverse childhood experiences and how that influences our thought patterns, our feelings, and then ultimately our behaviors and our actions. And how in medical school, what did they get wrong in our medical training? There is zero coverage of that. And there's some of it in psychiatry and some of it, depending on where you get trained, and it's limited to mental health, not really leaning into the fact that this affects chronic disease. This affects our metabolic health because this affects our actions, our behaviors, our decisions as it relates to how we eat, how we sleep, what our relationships are like, how we self-destruct or not. And that's a really important piece. And I'm now leaning in really heavily with my patients around this for them to explore this aspect of their life.
I love that you brought that up. So, we're going to talk in our next podcast about some of the training that you've done in Hakomi, mindfulness-based somatic therapy, to address these missing experiences that people have. And also maybe writ a little larger, the ways that trauma can map to, we know now from the ACE studies, 45 different chronic diseases. Not just mental health conditions like depression, anxiety, post-traumatic stress disorder, but autoimmune disease, diabetes. So trauma definitely has a really strong link to that. And I'll put in the show notes a link so that people can determine their ACE score and maybe come to our next podcast knowing what their ACE score is. So thank you, Brett Jacobs, for being with me for part 1. Looking forward to part 2.
Me too. Thank you so much for having me. As always, I really enjoyed our conversation.
Me too.